All right. Hi, everybody. I'm Jason Walonoski, and I'm sort of the principal investigator and project leader of Synthea, which I'll talk to you today about. I'm just going to dive in and get started. What is Synthea? Synthea is a contraction for synthetic health. It's an open source synthetic patient generator. We simulate patients' progression and treatment of disease from birth until the present day or until they die. At the end of the simulation, we output their health records. The goal was to output really high quality, realistic but not real synthetic patient records that were free from any sort of privacy or security restrictions that you could use for any sort of secondary use of the data for anything you want, like academic research, software development purposes, where realistic but not real data would be sufficient for your purposes. If that sounds useful, you can get started while I'm talking. You need Java, and you can clone a repository on GitHub /synthetic health /Synthea, and you can run Gradle to get it started, and that command run Synthea will generate a single patient for you. So if people want to get started on their laptops while I'm talking, you can start exploring that way, and I'll show this again later. So why synthetic data? So there's a high demand for EHR data sets, especially in software development and integration. There's a lack of access unless you work for a hospital system or a big provider. If you're a smaller company or an open source developer, getting access to this data can be really difficult. You can get it, you can buy and sell it, but there's risks with that. Obviously, real patient records, there's a lot of privacy and security risks with that data. And it's not really anonymous. Even de-identified data has been systemically sort of re-identified. There's like a famous case in Boston, Massachusetts, where they released some de-identified data, and all these statistical experts, guaranteed that it was de-identified. And within days, an academic research team had re-identified the data, including the governor of the state, and they released the governor's medical records. So even de-identified data is not really safe, so that's why we went to synthetic data. And we started this project because we're software developers. Everything I build is open source. And we wanted data sets that we could test our software with, and we also wanted data sets that we could integrate with other people and that would be safe for people to use in the open. And so we generated it because we needed it, but we put it out there so other people could use it too. This is a system diagram of how Synthea works, more or less. What we do is we start with clinical care maps. So these are basically the standard of care. There's no such thing as the standard of care, but we start with standards of care that we got from clinical specialty societies or peer-reviewed research. And we basically convert these into state machines. So all the developers in the room probably are familiar with what a state machine is. And we basically initialize those with disease incidence and prevalence statistics that we got from the CDC, the Centers for Disease Control. And we use that to basically create a synthetic population. That population is seeded with census demographics. So the software comes preloaded with US data. Sorry, I'm from America, and it's US-centric, but it is adaptable, and I'll talk a little bit about that, and I've exercised about that. But we take census data from the US Census Bureau, which is, so every named place in the country has statistics about how many men there are, how many women there are, what the different age groups are, all sorts of stuff about income levels, education levels. And we basically plug that in to seed a population. So if you want to run a town, you have statistical aggregate information about who lives in that town. We also load provider data. So there's a publicly available set of provider data and cost data. And we basically use that to seed the simulation. We run it on a time step basis, so we just start cranking, and we do it week by week. and every patient, sort of their disease progresses and gets treated until they die or until the present day. And at the end, we export complete longitudinal data of their health record. We also output claims and provider information. So it's not just patient records. There's also data in there about their access to care, so how people get care, how it gets utilized. There's health outcomes, so if anyone here is familiar with QALYs or DALYs, so the quality adjusted life years or disability adjusted life years, that's a metric from the Global Burden of Disease study. So we output that as well, so you can see how people's disease burden is changing over time. And then we also output different types of claims and explanation of benefits, so you can see where, how much their treatments cost and where it's coming from. And that ends up being a whole lot of FHIR resources, which I'll show soon. When we started this project, we started with 20 different diseases. I used to call them the 2 top 10s. So I wanted the top 10 reasons patients would go see a primary care physician. And so those are things like routine checks, health checks for children, hypertension, pregnancy, just the thing, everyday people going to the doctor's office. And then the other one was the top 10 list of what was sort of the years of life lost or your chronic conditions. So those are things like heart disease, different types of cancer, Alzheimer's. And when we combine that, you know, it's not everything. There's a very long tail of diseases that people can obtain. But it's a good sort of core chunk of what you would see in most EHR systems. Now we have about 90 modules today, and there's about 722 clinical codes. So there's a pretty good coverage of things you can find in there that might fit some of the use cases you might need. I hinted at before that disease modules are state machines. So I don't know if this is easy to see or not, but there's an initial state, and there's different states. Some of them are control, some of them are clinical, and basically it can branch and it can end. And these state machines are written in JSON, so that's just that JSON is literally this state machine on the previous slide. You don't need to know that the details, so don't worry if you can't read it. Like I said, some states are control states. They control how a patient will flow through the graph. And some states are clinical, and this will end up being the stuff that actually shows up in someone's health record. So you can see there's things like a procedure, things like observations or lab reports. At this time, what I'm going to do is I'm going to show you a particular module that's called exampleitis. So exampleitis is obviously not real. It's a condition that we made up for the purposes of giving presentations so people could understand what we're doing. Exampleitis, it's a condition that only affects men over the age of 40, and it can be fatal. It can also be treated with examplitol, which is a medication, or potentially you can have an exampelotomy, where they remove your example, but some people never recover. So keep that in mind. So we start with an initial state. So every model starts with initial state, and that's where you begin. And there's also a terminal state. Terminal doesn't mean death. It just means that's where the state machine ends. In this case, the first thing, if I click on this, I resized it a little bit. There's a conditional transition. And if you're male, you'll go one way, and the female will go other way because only men can get exampleitis. The next state is a guard state. So this is one of those control states. And basically, a guard is just to say, all right, a patient is going to be stuck here in this state until a certain condition is met. In this case, the condition that we set is we're going to wait there until they're over the age of 40. And then there's a distributed transition. And so it's just probability. There's a 10% chance the person is going to get exampleitis, which would correspond to a 10% prevalence rate of the disease. At this point, a patient, let's call him John Doe, he's 40 years old, and he's in a state of pre-exampleitis. And this is a delay state, so this is another type of control state. And what it does is there's a delay there of 0 to 10 years. So the software is going to roll the dice and say it comes up with 10. So in that case, John Doe, it'll wait there until John Doe is 50, and then he'll move on to this state. This is condition onset. This is obviously, well, it's a fake SNOMED code for example-itis. But at this point, John Doe now has example-itis. It hasn't been diagnosed yet, but he has the disease. And it says diagnose at wellness encounter. So what it's going to do then is it's going to wait until the next scheduled wellness encounter. So this is like the patient's annual physical exam. He's going to go there, and then that's when example-itis gets added to the patient record. The doctor's going to say, hey, you have example-itis, and we're going to try to treat it. We're going to prescribe you a medication, examplitol. So examplitol works for some people, in which case they'll sort of exit on this side. Other people, there's nothing that can be done, and they'll go into this state called last days, where they only have a little bit left of their life to live. But some people will require, including our fictitious synthetic patient John Doe, it's going to need an exampleotomy. The examplitol didn't actually work for this patient. It's going to have another delay, 18 to 36 months. It's going to roll the dice, and after some amount of time, they're going to have an encounter. And in that encounter, they'll have a procedure, the example-otomy. It takes 2 to 3 hours. And then they can end the encounter. They still might die. And then it goes to the terminal state. And then this model is over. And one of the things, if I click over here, you can see now, this is the JSON for that model that we just sort of walked through. And this is all online, and it's open source, and it's free, and you can look at the different models that we have. You can go through them all. Some of them are much more complicated than example-itis. Example-itis is very simplified, and some of the chronic conditions, say like diabetes, they'll actually be looping. It's not going to be like a straight through sort of walk. It's going to loop, and people's disease can progress and stuff like that. Let me go back to the presentation. Okay. So here again, I have the setup instructions if people want to jump into that. So you just clone a repo, synthetic health, synthea.git, change the directory in there, and then run Gradle. And for those of you who aren't familiar with Gradle, it's a build tool in Java, and it does all the dependency management and stuff. So once you get that going, you can run the Synthea command. What it'll do is it'll tell you it's loading all these models, and then it will basically run and give you some stuff about the seed. That's the random number seed, so you can recreate the same population later if you want. If you don't tell it what to do, it will just choose the state of Massachusetts, and then it will run a single patient if you don't provide any other parameters, and it will output that patient, in this case, a 10-year-old patient in Lawrence, Massachusetts, in this case. Synthea generates FHIR resources. It generates other standards like CCDA and different types of output, but since this is FHIR DevDays, we're going to focus on what it does in FHIR. So bundle, patient, encounter, condition, allergy intolerance, observation, diagnostic report, procedure, imaging studies. Imaging study will output the fact that there was an imaging study done, but you won't be able to get, for example, like a synthetic DICOM image, although I would love to do that. You can get immunizations, the care plan, a medication request, and then you can also get claims, the explanation of benefit, and coverage. Right now, the explanation of benefit and coverage I only have in the S23, but we do DS22, S23, and R4. Although the R4 is not up to date. We use, to output the data, we use the Happy library that people have probably heard about this week, or you've used before. Happy had a release about a week ago, but our implementation is about a month or two old, so it does need a little bit of updating there. And then, of course, that's a sample of an observation patient blood pressure. So once you do that, what ends up happening is it outputs a bundle. It's a FHIR bundle. The first thing in it is the patient resource, And then it's all the encounters that the patient ever had with all the diagnosed conditions and all those other resources in it, and they can get quite large. When you have a total history of a patient, you can have lots of resources, it turns out. So what you can do, this is just an example of running curl. You can use whatever Postman or whatever your favorite FHIR client is. There's lots of FHIR clients out there. In this case, I happen to be posting it to Happy, and then it turns back a response and says, yep, 201 created, I got your transaction, and all those resources are there, and you can go get them. So it's pretty simple to generate, and then you just post the bundle to a server. Now, there's a lot of configuration settings that you can tweak. We have pretty good documentation on our wiki, so if you go to the GitHub site, in our wiki, there's quite a bit of documentation about how you can run and configure the system and try to get you into it. In this case, there's some exporter settings for FHIR. So by default, it outputs FHIR S2.3. And you can, by default, it outputs bundles that are transaction bundles. You can also get, for those who are familiar with bundles, you can get collection bundles, which are slightly different organization. There's different extensions that we allow it to use. And then there's separate parameters for if you want to go back and use DS2.2 or if you want to use R4. But the default right now is S2.3. There's also separate settings here to output hospital data, or and not shown here is another set of settings for outputting the practitioner data. So if you want just a bundle that's just all the information about the hospitals or all the information about the actual synthetic clinicians that are there, you can have those outputted separately. And there could be uses where you would want that. So at this point, you may be asking yourself, well, how are other developers using Synthea? So I have a list of different examples of where people have used this. HSPC is the Healthcare Services Platform Consortium. They have some sandboxes that you can create as developers online. You go to their website, you click some buttons, and it creates a FHIR server sandbox for you, and one of the options is you can have it preloaded with synthetic patients that are generated by Synthea. The Smart Health IT group, they have a bunch of different projects where they use Synthea data, including their prototype of their bulk data server. There's a company called Algerix Health that's in Massachusetts, and they use Synthea data because they're looking at open clinical analysis. So they have a series of blog posts where they write about data analysis and data analytics in health. And they want to, talk about how you can do it and demonstrate different things. Well, obviously they can't use real data. Most people don't want to use de-identified data either, or they can't because of the data use agreement. So they use Synthea data for a lot of their online demonstrations and blog posts. My company, MITRE, has created a site called Synthetic Mass, which is, we simulate the state of Massachusetts at 1/7 scale. So there's about 7 million people in real-world Massachusetts, but our synthetic mass only has 1 million people. And so we have 1 million simulated patients. It's a slightly older version of FHIR, but the data's all there, and you can download 1 million patients and get going if you want. So Microsoft has a series of blog posts about how they used synthetic data in different parts of their Azure cloud. And if you saw the Microsoft FHIR presentation yesterday, they loaded that with Synthea data. So it gets quite a bit used. And then one last thing. So at the last DevDays talk, which was in Boston, Cerner came, and Cerner used Synthea. They have a tutorial called Bunsen, where basically they use Apache Spark in a Jupyter notebook, and they do a bunch of clinical data analytics. And they have a tutorial, and that's preloaded with Synthea data. And then Google uses Synthea in their protobuf example. So if you go to their BigQuery demonstration and protobufs, there's some example code that relies on Synthea for that demo. So, and then the question I ask is, what will you use it for? I encourage you to use it. I invite you to use it. I also invite you to submit bug reports or come talk to me and I can help you. If you go onto the FHIR DevDays website, there's a set of tutorials and exercises that I developed that are there. So there's 4 different ones. The first one is pretty simple. It's just how you install, configure, and run it. That's easily done. It's basically just check it out the repository and run it in a couple different ways. There's another use case that sort of just uses the synthetic data. There's another one that explore and sort of modify the disease model. So if you want to get into the modification of any of the state machines of how the diseases work, there's a tutorial that shows how you would do that. Most people will want to just generate and use data, but there are people out there who want specific things to show up in the data. So that tutorial will show you how you can actually modify those modules. And then the last one, and this is a challenge, I guess, is to localize it. So I have instructions out there about how you can modify this for places outside the United States. The instructions are pretty good. No one has ever done it. So including all the other DevDays and other places I've gone to. So if you can complete this challenge, if you're up for the task, take a look at exercise 4. One of the things I show, if you look at the exercise, I give you an example of how you could do it. There's one town that I did in England. But if you want to sort of show you how you would do it, and you need basically a lot of data, so you have to figure out a lot of statistical information about what your population looks like, where the different hospitals are, but it can be done. A lot of people ask me what the roadmap for this project is. Currently, just to sort of talk about this again, we support DS22, S23, and R4. We comply, the FHIR that gets outputted complies with the Argonauts implementation guide. That's sort of US-centric, but if you're familiar with what that is, we comply with that. We also output our some of the financial data we output is Blue Button 2.0. So if people are familiar with what that is, that's an implementation guide that the Center for Medicaid Services, CMS, they have their data available in this Blue Button, and we output our financial data in that same implementation guide. We also support JSON. As of last week, we support ND-JSON, so that's the bulk format. But what's next? Well, obviously, we want to stay in sync with FHIR. We did this because we are FHIR developers, and we wanted data for FHIR. So as FHIR evolves, you can be sure that this project will evolve along with it. As different implementation guides come out, we won't necessarily support them all, but there's probably some that we'll want to natively support as certain implementation guides sort of become more and more important. One thing that people have asked me for quite a bit is terminology variation. So I'm guessing that usually there's a question about what terminologies we support. And basically, out of the box, it's SNOMED, LOINC, and RxNorm. So if you use a different set of terminology codes, you'll have to play around and modify it to support that. But there's been requests about how we can make it a little bit easier for people to substitute their own terminologies. So we'll be looking at that. Another thing I get frequently asked for is splitting the record. So right now we output a single bundle, which is the patient's complete sort of longitudinal health record. And people, I guess it varies around the world, but in the United States at least, your record is split by every single provider. So, if I went to a doctor in Boston, he's going to have part of my record. If I went to a different doctor in Worcester, he's going to have a different slice of my record. So a way to split the record by provider so that you have to do things like patient matching, record merging, different things like that. But we don't do that today. Another thing we want to add is clinical notes. So right now everything is structured data, and people always ask me for clinical notes. Like, I want clinical notes. When are you adding clinical notes? And my answer is, we take pull requests. But in the meantime, actually, we were looking at it. Theoretically, if you have structured data, it shouldn't be too much of a challenge to generate narratives from it. Obviously, it's much harder going in reverse when you have narratives and you want to do NLP and extract structured data. So, we have sort of the easier direction. It's not there yet, though. Then there's some other things that we want to look at more that are more on the patient side about how patients behave, looking at health disparities, determinants of health, and other stuff. Here's my information. I'm slightly ahead of schedule. There's my contact information. There's the repo for Synthea itself. And there's that link to the module builder, which is the editor that I showed about how you can sort of browse through the different disease models, and you can edit them there. And don't forget to take a look at the exercises. I've been hanging out at the developers table over there. So if anyone wants to work on the tracks or the exercises, please feel free to get in touch with me or ask me for help. I mean, that's why I'm here. I'm here to help you guys. So feel free to come and talk to me about it. And I would like to thank FHIR and the different partners for the opportunity to come to speak with you all today. So thank you. Questions?
Thank you for the talk. When you made the model that does the synthetic population, how sophisticated is it in terms of actually modeling people? Like, have you got comorbidity and stuff like that? Like, do your synthetic patients get the same things?
Yeah, so the question about comorbidities. So it's a good question. Some of the models operate independently, and some of them have interdependencies. So you'll tend to see certain it depends on who wrote the disease model and how they tied it to other models. In some ways, in the internal data model of a patient, you can think of it as a whiteboard or a blackboard where you basically just write stuff down. And so the different disease models can look at that and say, well, what does this patient have right now? Oh, they have hypertension. Well, there's some stuff that I want to do now that goes along with that. So you can tie them together that way. So things like diabetes and hypertension have comorbidities. There's an attribute for whether the person smokes or not. So, news spoiler, smoking's really bad for you. If you smoke, you're going to have a much higher rate of certain conditions. And so the synthetic smokers, you'll see all sorts of comorbidities related to that, like asthma and lung cancer and COPD and all sorts of stuff. So it depends. It varies. In some cases, you'll see a lot of comorbidities that make sense. But in other cases, they're not explicitly tied. Yeah. Anyone else?
I was wondering if there's the possibility of interaction between simulated patients. So for infection control, I have one patient at one location, another at the same location. One has the infection, the other one has a higher probability acquiring this infection.
Yeah, that's a good question. So every patient has a latitude and longitude, and we've even experimented with giving them workplaces and places where they go to school, so there'd be intermingling. But right now, we do not support infectious diseases like, zombie plague, and then, zombie plague occurs. We don't have that at the moment, but we have talked about it and be interested to do it at some point. So if that's something that's really important to you and you want to help out, I'd love to have a talk, and maybe that's something we can look at in our roadmap.
Okay, thank you.
Anyone else?
Did you talk through the history in one of the slides that I missed? Yeah. Did you talk through the history of the project in one of the slides that I missed earlier? Maybe you could give a brief outline of it.
Yeah, I didn't really talk about the history so much, other than that we're software developers, open source in health ourselves. We do a lot of work on FHIR, and we always wanted data that we could either demo when we had people coming through, or that we could talk about when we were at conferences, or that we could use for integration or exchange with people. We didn't want to, you didn't have to set up a data use agreement. You don't have to do anything because it's all unprotected. There's no reason to protect any of it. So that's why we did it for our own purposes. And then we started building it out in the open on GitHub just so that we figured, you know, we've always needed this. We wanted it for about 10 years before we finally got around to building it. And we figured other people would want it too.
Did you validate, or how did you validate your model against the real world?
Yeah, so the question's about validation and how do we validate it. Yeah, I could give a whole talk on that. That's another 20-minute talk, validation. But the way I look at it is, well, first, there's a quote that I almost always use. I didn't use today, but now is a good time for me to use it. So George Box is a famous statistician, and he said, all models are wrong, some are useful. So the question is, I'm not going to claim that any of these models are correct. The question is, are they useful for your particular use case? Now, in terms of validation, I look at it in terms of three ways. One is, if I look at the statistical aggregates. So if I look at the population, and I look at, did I get the demographics correct? All the distributions? Did I get all the distribution of disease correct? I also then look at it at the patient level. So if I take a patient record and I throw it in front of a physician, what are they going to do? Are they going to laugh at it? In the early days of this project, the answer was yes, they would laugh at it. We had some very humorous interactions where doctors would look at the records at first and they would say, you made a rookie mistake. Here's a drug-drug interaction. This person would be dead. And we'd fix that. And over time, we got them better and better. So we do that. We periodically do those kind of validations. And the statistical. Oh, and then the other thing is the models themselves. So we've taken some of the standards of care that we have, and we've shown those to physicians and be like, how wrong is this? And sometimes they're like, well, this is totally wrong, and then we change it. And other times they'd be like, well, it's not perfect, but it gets about 80% of the way there, and there's all these special corner cases, and we're like, nah, we don't really need that for what we're doing. So, we validate the model, the standard of care, validate the patient records, and then also all the statistical aggregate kind of stuff. And there's many other ways you could do it, but that's kind of the approach we take, and we do it periodically.
Thank you.
Yeah. Anything else? No? All right, thank you, everybody.